Host.
Okay. So this event's being recorded for anyone who may need to step away or for those who would like to share with others afterwards. And for our audience members and fellows, since we have a pretty tight schedule today, any questions that you might have for our fellows, I ask that you put them in the chat box and Javi, who is directing our fellow presenters to the chat box to answer them. And I want to thank my subcommittee co-leads. I want to thank Javi Andrade, who's monitoring the chat. Yay, Javi. Jonathan Brewer, who's looking at the scores, and Sandy Warner, who is making sure that all the presenters are co-hosts and up to date. And they work just as hard as I did. I just happened to be talking. They're working behind the scenes to make this event possible. And I want to recognize our 11 incredible fellows and mentors, all of whom dedicated a tremendous amount of time to be here today and to prepare for the day. And lastly, I want to recognize our judging panel. And before we begin with our first presenter, I would like to introduce our four-person judging panel. So judges, in lieu of submitting formal bios, I decided to Google all of you and let my internet searching collectively assemble your introductions. Fortunately, given how accomplished all of you are, that actually was much easier than I expected. So I'm going to introduce you by what Google and ChatGPT, mostly Google, thinks of y'all's. So starting with Dr. D. Coneybear. Uh, this is from Core EM and Scuff. Thank you. Dr. D. Coneybear is from Portlandia and is an associate professor of emergency medicine and ultrasound fellowship director at Columbia University. She has held numerous national leadership roles, spearheaded initiatives for ACEP, Scuff, and SAEM, as well as received educational awards from SAEM and ACEP, and she is the current president of Scuff. Yay, welcome, D. I'm gonna
Thanks,
do
Jeff.
yay. Okay. Next, we have the esteemed Dr. Megan Hilbert. This is from the ACEP ultrasound webpage. Dr. Megan Hilbert is an emergency physician practicing in Salt Lake City. She has interests in point of care ultrasound education, curriculum development, and regional anesthesia. And she has also received multiple teaching and clinical excellence awards and currently serves as the newsletter editor and secretary for the ACEP emergency ultrasound section. Yay, Megan. Yay.
Thanks for having me.
I'm gonna react with congrats symbols on my video. Yay. Yay. I've learned how to do that too. Um, Next, we have Dr. Meera Muruganandan. This is from the SAEM webpage. Dr. Meera Muruganandan is an assistant professor of emergency medicine at Boston Medical Center and Boston University, where she serves as director of ultrasound. She is internationally recognized for developing point-of-care ultrasound curricula and training programs in resource-limited settings across countries such as Sierra Leone, Uganda, Haiti, and Rwanda, and she is the current president of the Academy of Emergency Ultrasound from SAEM. Welcome, Meera. And let's see, last but not least, I have the good Dr. Francis Russell. This is from the Ohio ACEP webpage. Dr. Francis Russell is a professor of emergency medicine and ultrasound research director at Indiana University. Her research focuses on point of care ultrasound in heart failure, dyspnea, and medical education with over 50 peer-reviewed publications and multiple NIH-funded projects. She has also held national leadership roles in SAEM and ACEP and received awards from AEUS from her research endeavors. Yay. Wait, I forgot to do the React rockets this time. Yay. Okay. And judges, a reminder that each speaker gets one submission from each of you, and we will be averaging your scores to help to get to the winner. And please reach out to either myself or Jonathan if you guys have any issues. We'll be watching from behind the scenes. And we are already 5 minutes ahead of schedule. Our first speaker is Dr. Aaron Kane. And Aaron, are you ready? I'm a little bit ahead of time, but if you want to give for yourself 5 minutes, you
Sure,
can.
we can let it rip.
All right. So I would like to introduce our first speaker. This is Dr. Aaron Kane. His mentor is Dr. Chris Tom, and he will be speaking to you about probe to payment, reducing revenue loss in your ultrasound program. And Aaron, you can go on ahead.
All right, can you see that?
I can see your screen and I can hear you.
Sweet. I guess since I'm first, I'll thank you guys all for having us. I'd also like to thank Chris Thom over at UVA for his help kind of putting this all together. I'm going to be talking to you guys kind of about basic billing stuff in the emergency department and what we do in the ultrasound office, and maybe a few things you can take home with you to kind of cover increasing your kind of revenue that you're making at your department. So we're going to go over a few different things. We'll go over some very basic kind of billing requirements, some common pitfalls, and then maybe a couple things to go home with you. So the first thing we'll go over is going to be our components of billing. So there's 7 main components that we talk about when we're talking about billing for ultrasound. These are set by the CMS. So each of your studies that you're doing is going to have all of these things in them. And, coming from a fellowship program, probably most of you guys already have this kind of stuff set up. But if you were to be going somewhere that was maybe setting up a new program, I would pay attention to, the CMS requirements for what you guys are putting into when you're documenting the ultrasounds that you're doing. Another thing we'll cover is going to be limited versus complete ultrasound. So limited ultrasound is typically all that we're doing in the emergency department. It's going to be, very specific questions. So for an example, it's going to be a right upper quadrant ultrasound, where we're really only getting the CBD and the gallbladder. That's going to be worth about 0.58 work RVUs. It has an associated limited CPT code with it. Whereas complete ultrasound is going to have much more like robust documentation requirements. These are the studies that radiology is doing. So for like a complete ultrasound of the abdomen, you're including the liver, the spleen, the gallbladder, the pancreas, et cetera, et cetera. And that's really only worth a few more fractions of a work RVU, honestly. Whereas there are a couple ultrasounds where there's really only one CPT code, so there's no limited versus complete CPT code. So even though in the emergency department we're still doing a limited transvaginal ultrasound or a limited transesophageal ultrasound, there's only one real billing code for it. So they're really only going to bill for that single one. And then finally, we'll talk about professional versus technical fees. Professional fees are what we are getting billed for in the emergency department from our ultrasounds, whereas the technical fee is going to be billed kind of the overhead and kind of how the facility bills it. So the professional fee is going to be a much lower component, whereas the technical fee is going to be much larger. The technical fee is kind of derived out of the OPPS system and has an associated APC code. There's really only 2 APC codes that we have in emergency ultrasound. Most of them are around the $100 mark for what you're getting for those technical fees. But the echocardiogram is actually almost double that, where you're getting $240 back for that APC code. You'll notice that obviously the professional fee is significantly less in this scenario. So these are really important things to understand about, especially when you're going back to your program and you want to talk to them about, trying to figure out what kind of overhead you guys are going to have. And especially if you're trying to buy new machines or hire new staff, it'd be good to have this to be able to set realistic expectations for when you're trying to have these discussions. The next thing we'll go over is a couple common pitfalls for where people kind of lose revenue out of their emergency department ultrasound program. Pitfall number 1 is kind of related to how you're billing for your ultrasound. At most of our academic ultrasound programs, we're going to be billing our ultrasound procedure CPT codes in and of themselves. Whereas in some of the more rural ones, they're maybe not saving all of their images and documenting them the same way. They're actually just going to incorporate it into their E&M codes, where they're just going to bill it as part of their personal review and interpretation of images. There is this sweet spot kind of in the middle where you can actually use your POCUS to bump the MDM up from one level to the other. But in that scenario, you can't actually bill the POCUS as a separate procedure. So the question you should be asking, and your billers should be asking, is POCUS what's needed to bump this MDM from one E&M code to another E&M code? If the answer is no, quick, easy, bill that ultrasound separately. It's often going to be worth more RVUs in that way. But if the answer is yes, and you need it to bump your MDM level to a higher E&M level, it would actually be more prudent to include it in your MDM section, so you're making more money from it. This is important to work with your billers and coders, especially closely when you're kind of having this conversation, because it's not very many patients that it actually comes up to, but it can actually be a pretty significant jump over time. An example of this, we'll go through kind of a 52-year-old male came in with chest pain, gives a pretty good history for kind of a pericarditis kind of picture, was sick recently, has diffuse ST elevations. You kind of work them up from a cardiac standpoint. Labs all look fine. Chest x-ray looks okay. You give them some symptomatic control and you do a POCUS that doesn't really show much. So kind of based on, just a basic kind of workup in MDM, and you don't do any specific like personal review and interpretation of your EKG or your chest x-ray, and you're really only doing labs and you're not documenting everything, That's only going to get you to a level 3 visit, which is worth 1.6 work RVUs. And then you're going to, if you were to bill that ultrasound separately, that's worth another 0.52 for that echo. That's going to get you to a total of 2.12. Versus if you were to include it in your MDM, the only difference you're going to see on the right-hand side here is really that you're now personally reviewing and interpreting that cardiac ultrasound, and that's going to bump um, your E&M code up to a level 4 and is now going to be worth 2.74 work RVUs. Kind of the real kind of sweet spot is going to be, if you really go in and you personally review and interpret that chest X-ray or that EKG, because now when you go in there and you kind of bill it, now that you're personally reviewing and interpreting that chest X-ray, you can now bill for that ultrasound separately because it's no longer needed to bump you up to that next section. And now you're getting the level 4 chart plus the other 0.52 RVU work RVUs for the associated procedure with the echo. The next pitfall, tell me if you've heard of this one before, ghost scans. I'll chat GPT right there. So obviously you guys probably all know what a ghost scan is. It's a POCUS that's performed but never gets documented and ultimately never gets billed. There's some, problems that happen with ghost scans outside of, it's getting done and you're not able to document it from a legal standpoint. But there's also, a significant revenue problem with this as well. Particularly in orders-based workflows, this can be partially problematic, especially in, trauma patients or medical patients that come in and need their scan done immediately. And it's kind of cumbersome, honestly, to go backwards and kind of re-document that study. A way around this would be something like an encounters-based workflow where, you're able to get your pictures and then after the fact kind of scan your patient in to be able to get it. So reducing ghost scans is going to be a really important opportunity for most places to really increase their ultrasound revenue. A recent study of about 6,000 patients came out in 2025, showing a significant amount of scans are going unbilled out of trauma centers. Kind of from that study, I'll show you guys the best and the worst site. It was a 4-site study. The best site only had a ghost scan rate on their trauma fast of about 21%, whereas the worst site had a whopping 93% of their trauma scans were going unbilled and undocumented. So that really only leads to about $1,000 in gross revenue from those work RVUs, not including the overall technical fees and all of that kind of stuff. So it actually is a little bit bigger. If you were to take these sites and you were to decrease their ghost scan by about 50%, you're going to see a big jump in the number of studies that are saved, but you're also going to see a big jump, especially in the worst site where they were really only saving 70% of the studies. You're going to see a gross revenue from the work RVUs alone of roughly $7,000. You don't see the big jump if you're obviously really good at saving your images and not having ghost scans, but the more ghost scans you have, the more money you're kind of leaving on the table. So you're literally burning money off of your probe as you're kind of going through these ghost scans. And then pitfall number 3, we'll talk about difficult workflows. It really comes down to the thing that's going to get you more ultrasounds is going to be making it as easy as possible, especially for people that are not ultrasound trained to do ultrasounds. The harder it is, the more documentation burden they have, the less ultrasounds that are going to get done. So things you can do to decrease friction that is needed to kind of do your documentation associated with ultrasounds is going to be implement dot phrases, smart forms, things that are going to make it easier for your providers to come back and your physicians to come back and just click through real quick what was needed. Another study recently came out and had an EHR deficiency alert where they would alert the doctor 2 days after the ultrasound was done that their POCUS note wasn't written, and that actually increased their compliance as well. Other things such as like having a middleware where it automatically sends your information off to the EHR after you attest it can decrease the amount of extra work on the backlog to make things easier. And then simplifying your workflows ultimately is what's going to make things significantly easier. Stuff like encounters-based workflow, all that kind of stuff essentially is going to make things easier for people to want to do ultrasound so they can bill for those ultrasounds too. So friction in documentation ultimately is going to lead to decreased billing out of your program. And then finally, we'll talk about a couple kind of quick action items. So there's 5 quick ones here. So really go through and audit your documentation. Take a quick sample of the POCUSes that are being done when you're kind of doing your QI. So go through and make sure that you're meeting all of your requirements for your CMS billing completeness. Evaluate how you're billing your codes through either if you're going all through MDM or all through billing, or if you really can find that sweet spot where the ultrasound is really that one piece of information that's needed to bump your E&M code up from one to the other. And then finally, assess your workflows, evaluate if encounters-based workflows might work for you. That could probably help decrease the number of ghost scans, or if you guys need to implement something, if you're an orders-based workflow for a way to kind of backlog those studies that are being done. And then finally, I would monitor the reimbursement that you're getting from your billers and your coders and the reimbursement, as well as track the trends for what you guys are billing. Doing all this kind of stuff is going to give you information and kind of how to project going forward and have discussions with kind of hospital leadership as you're moving forward. So just some quick, thoughts and ways to kind of evaluate how you guys are billing out of your guys' programs, and things to keep in mind when you're having discussions with your hospital leadership. Here's a couple resources. Thanks for having me, guys.
Thank you, Aaron. That was a wonderful presentation. I'm happy to say that I think we were one of the sites in that Go study article, and we were definitely not the best, but not the worst. So that's where I've lived my entire
Yeah,
career.
I tend to think that most fellowship programs probably fall on the side of the better side.
Let's hope that continues. So we will be moving right along. Our next speaker is Christine Donat, and her mentor is Matthew Lipton, and she's going to be talking to us about the UJVP. So go ahead, Christine.
All right, thank you. Can you see my slides?
You can see your slides, and we can
All
hear you.
right. So imagine you've just arrived for your shift at the ED, and you hear an overhead message calling you to the resus bay for a medical patient. On arrival, EMS states that the patient has half rev and is presenting an undifferentiated shock. You wonder if they'll be able to tolerate fluids, and your resident has thankfully just rolled the ultrasound machine into the room. You get ready to plop the probe down, but you look at their abdomen and see this. The resident on the computer in the corner notes that the patient was recently in the SICU and they had a bowel resection, which explains the stressing that you probably don't want to mess with. Seeming to pop out of nowhere, the IM resident rotating through the department says, why don't we measure ultrasound JVP instead? We use it on the inpatient side all the time. And that resident was me. Hello, my name is Christine Donat. I'm an internal medicine and emergency medicine ultrasound fellow at Yale, and I'm excited to present to you Ultrasound JVP Untapped Potential. Now, you may be wondering, what is ultrasound JVP, or UJVP for short? Well, the best place to start is to refresh on what JVP is exactly and go from there. The bottom line is that JVP is a simple way to estimate right atrial pressure, and in this case, to determine if our patient is volume overloaded. And though I'm sure that you're probably measuring JVP on every patient that rolls into the resus bay, a quick rundown is that you start with patient at about 45 degrees and look at the neck veins to find the highest point of elevation that they reach. The height is measured to the sternal angle, and then 5 centimeters is added. The additional distance is added to account for distance of right atrium to the chest wall. And the bottom line is that more than 8 centimeters is considered elevated. Now, of course, JVP is only estimating right atrial pressure. If we want to directly measure it, you have to use a Swan-Ganz or right heart catheter. And a quick reminder on this, depending on when last time you floated a Swan was, for me it's been a little while. Right atrial pressure is measured by placing the catheter directly in the middle of the right atrium. And it's as simple as looking the highest pressure tracing on the monitor thereafter. Now, not every patient's JVP is going to be as easy to assess as this person's. Quite often, factors like obesity, neck length, lighting, and difficulty distinguishing it from carotid pulse can prevent you from getting a reliable measurement. In this case, UJVP will be your friend, and it's really easy to do. Here's how it's usually done. So you start with the patient at 45 degrees, just like with the physical exam technique. Though my friend here is a bit more reclined for demonstration purposes. You simply start with a view of the right IJ, marked here in blue, and the right carotid, marked here in red. You follow the IJ vein superiorly until it's smaller than the common carotid for the entire duration of the respiratory cycle. And as I slide superiorly on the neck here, you can see the point at which the IJ is smaller than the carotid. The height is then measured to the sternal angle. And if you don't walk around with two rulers, you can measure the distance between your index and middle fingers. For most people, it's around 6 to 7 centimeters. And then use this known distance to estimate JVP elevation. And just like in normal JVP, you add 5 centimeters, and that's it. It really only takes a few seconds to get a good UJVP measurement, and it gives you a lot of information. Now, sometimes, honestly, not often, but it may be difficult to visualize the vein in a short axis for one reason or another. So an alternative approach is to visualize the jugular vein in the long axis. This can be seen in the top right, and it can be followed superiorly to the tapered meniscus, which resembles a wine bottle, often described as wine bottle sign. On the bottom right, the view is swept to the common carotid artery to compare their sizes. And after comparing the size of the IJ with the carotid, you find where it's smaller in comparison and mark it. And I would say that's about here. And practically, you can also line up the center of your probe with the point that you think is the smallest for your measurement. So now you know that UJVP is really easy, but then you wonder, is there any evidence that this is any good? And you find this recent article from the Annals of Internal Medicine, which suggests that POCUS UJVP is feasible, reproducible, and accurately predicts elevated right atrial pressure in patients undergoing right heart cath, which is the gold standard. This was performed to validate POCUS assessment of JVP, to predict elevated central venous pressure, which is essentially the same as right atrial pressure, as measured by the gold standard of right heart cath. So there's two ways that they assess UJVP in this study. The first is the quantitative UJVP, which is measured with the patient at 45 degrees. This is the same technique that we just discussed. But they also studied a second method as an alternative approach, qualitative JVP. This was instead measured with the patient at 90 degrees and is a little bit more practical for daily practice, especially in the ED where you're moving quickly. With the patient upright, if the patient had any IJ distension greater than the carotid at any point, it was a positive. And I really like that they did this additional method because I think it can be particularly helpful in real life for our patients when they are in respiratory distress and need to be sat upright. When compared to right heart cath, UJVP results were strongly correlated for right atrial pressure measurement, with a correlation coefficient of 0.79. Area under the curve was also strong at 0.84, with a UJVP cutoff greater than 8 centimeters chosen as the optimal threshold for detecting elevated right atrial pressure. And this is the same as physical exam, if you recall. For the quantitative UJVP measurement, greater than 8 centimeters with the patient at 45 degrees, had a sensitivity of 73% and a specificity of 79%. And importantly, this is on par with IVC test characteristics. For the qualitative UJVP, measured at 90 degrees, this had a sensitivity of 55% and a specificity of 95%. And what this means is that if the IJ is bigger than the carotid at any point in the neck on ultrasound, when the patient's in this position, it's highly specific for elevated right atrial pressure and is a good way to screen for volume overload. As a pro tip, If you want to be even more accurate, you can consider directly measuring the right atrial depth because there's a lot of inaccuracies with a 5 centimeter additional assumption. And this is easy to do. In order to measure this yourself, start from parasternal long axis and go to the depth of the non-coronary cusp. At the posterior LVOT, this can be recorded as the right atrial depth. So it really just takes 1 second to do. And the non-coronary cusp marked here in purple is a good surrogate for right atrial depth because in parasternal short axis view, this approximates the middle of the right atrium, marked here in orange. So when is this helpful? Well, UJVP can be helpful in patients with abdominal dressings, when bile gas is obscuring IVC views, in patients with elevated abdominal pressure, such as cirrhosis and ascites, and in patients whose abdomens are not accessible, for example, if a nurse is placing an IV or doing other important tasks. So coming back to our patient now. The patient's upright UJVP measurement was positive, which is highly specific for elevated right atrial pressure, and you held off on fluids. They were later admitted to the CCU for cardiogenic shock. Yay, you learned something new from the medicine resident. Whether you can teach them all they need to know of emergency medicine in their 2-week rotation still remains to be determined. A special shout out to Dr. Matt Lipton for being an exceptional mentor for my talk, and also to Dr. Lipton as well, who happens to be his father, for writing the foundational UJVP paper. And I'm happy to take any questions that you have.
Thank you, Dr. Donut. That was wonderful. Shout outs. Excellent. Any questions for her, please feel free to put in the chat. I learned so much from our internal medicine colleagues, especially since they think I'm dumb. We will be moving right along. Our next presenter is Dr. Courtney Smith. Her mentor is Dr. Juana sorry, I butchered this. Campizano. She is going to be talking about closing diagnostic disparities with ultrasound in rural emergency departments. So, Courtney, you can feel free. You are up. Let's see your screen.
There we go. Got myself unmuted.
Nice.
All right. So thank you again for letting me talk about how ultrasound can fill diagnostic gaps. I have no disclosures. So the reason why this topic is extremely relevant to hopefully our audience and the broader ACEP audience is that at many emergency departments around the country in community hospitals, there is radiology delays. There may not necessarily be availability of all the subspecialty consultants that we have at our academic centers, and interfacility transfers can significantly delay patient care, as well as put a huge strain of resources on these hospitals. And the misnomer that rural settings don't see these highly sick patients is not true. So the reason why POCUS can help fill this gap is that it is available at most emergency departments, and any emergency physician can provide this tool immediately at the bedside. It can be used to guide triage as well as disposition and planning for patients, and being able to specifically identify who is the sickest patients in most need of the limited resources that you have. And it's very simple, and it's focused on decisions, using your POCUS to answer a very specific clinical question. So I have a couple of cases here that I wanted to present as kind of examples of why this is relevant. So our first case here is we have a 60-year-old male who presents with abdominal pain. His initial vitals are shown. He has some significant past medical history of CKD, heart disease, hypertension, and diabetes. And the specific hospital setting that you're practicing in has a CT tech that's on call, but has a 30-minute response time. And so you grab your point of care ultrasound machine, you bring it into the room, and you see these images on screen. Now, hopefully you're all able to recognize that this is a case of a type A aortic dissection with associated tamponade. You don't need the CT scanner to be able to make this diagnosis, and you can disposition this patient, whether it's calling your CT surgeon in to the hospital or getting the transport arranged for this patient without waiting for that CT, which can significantly delay disposition as well as affect the morbidity and mortality for this patient. Our next case here is that you have two patients that are coming into your rural emergency department at similar time. You have this first patient who's a 55-year-old female who's short of breath. Her vitals are also shown here. She's tachycardic and tachypneic. She has multiple medical problems, including heart failure, COPD, diabetes, and heart disease. At the same time, you have a 22-year-old female who's presenting with abdominal pain, a very common chief complaint that we all see sitting in our waiting rooms. And she doesn't have any medical problems, and her vitals are overall pretty stable. Your resource limitation that you have here with this hospital is that it is a 1 hour transfer time to your nearest tertiary care center. You are associated, though, with a small hospital with a couple of OBS beds available, as well as a hospitalist who's available to round on these patients. And so you grab the bedside ultrasound, you bring it into the room, and you start scanning these patients to try to figure out who is the most in need of your resources to transport. So you first look at that 55-year-old female with shortness of breath, and you see this finding. You see some B lines as well as some pleural thickening. You also see this significant consolidation. So at this point, concerning for a possible pneumonia. We see that this patient has a hyperdynamic heart, concerning for could this patient potentially be going towards septic shock. And so you can initially start with resuscitation of fluids as well as starting on some broad spectrum antibiotics. We're going to proceed on now to our second patient. And again, this is our 22-year-old female with no medical problems who's presenting with abdominal pain. You get some initial labs that show that she has a beta HCG quant of 800. And on further history, she's also reporting some vaginal bleeding. So here we have a transabdominal ultrasound that shows that there is some free fluid in that right adnexa, as well as a concern for a tubal pregnancy. You then proceed on to do a fast exam, and in your right upper quadrant, you see some free fluid. Now I go back to ask you the question, you have those two patients and you have one ambulance. Who are you going to transfer? So hopefully you're all in agreement with me that patient one, we can admit this patient locally to that hospital that has a hospitalist available. We can start them on antibiotics, nebulizer treatment, steroids. Well, they don't need an immediate cardiology evaluation or any sort of subspecialist initially. While patient two has a surgical emergency and needs to be in the OR now. And so you're going to prioritize transporting that patient with your single ambulance that you have available. And lastly, as somebody who's very passionate about global health, I think ultrasound has a huge impact on these patients who have even more resource limitations. So in this case, you're seeing a 75-year-old male who's presenting with chest pain for the past 3 days. He had to walk a pretty significant distance to get to your hospital. His vitals are shown here. He is tachycardic as well as tachypneic. He doesn't have any medical problems because he hasn't seen a doctor in many, many years. You're at this hospital where you don't have a CT scan available at all. The nearest hospital with a CT scanner is over an hour away. So you initiate getting a bedside ultrasound. You look at his lungs and you see some A lines without any significant B lines. You then proceed on to look at his heart, and here you can see some pretty significant dilated right heart with a D sign concerning for right heart strain. You then proceed on to do a lower extremity DVT ultrasound, and here you can see the clot. And so at this point, I don't need a CT scan to definitively say that this patient has DVT as well as highly concerned for a PE in the setting of having that right heart dilation and D sign. And so I can initiate treatment of either thrombolytics or heparin, depending on what's available, and getting this patient admitted, even without necessarily having that CT scan to assess his clot burden. So some high yield applications of where this ultrasound can be very useful is assessing patients in shock. We sometimes might have more than one patient at a single coverage ER. And so being able to assess patients for shock, as well as the patient who presents with dyspnea and chest pain, who has multiple comorbidities, first trimester pregnancy, as we discussed, as well as even biliary pathology to identify who needs an emergent surgical evaluation and who can be referred outpatient to a clinic setting. In all of these examples, I'm talking about very limited protocols where we are asking a very specific clinical question of how POCUS can help us to be able to triage as well as decide who is in most need of our very precious resources. This is not doing comprehensive exams. This does not replace the need for more thorough imaging, but it is essential in the initial workup of these patients to help when we are very strapped for resources. Some common pitfalls that you may see when trying to implement this protocol is that sometimes the person who's doing the imaging can be overconfident in their ability to make the diagnosis. Sometimes our images are not adequate in order to make those differentials, and we shouldn't overcall things if we're not confident in our ability to make that diagnosis on the limited imaging that you may have. We also may find incidentalomas if you're doing a renal ultrasound, for example, and you see a cyst. Well, that's something that needs follow-up. How do we have a pathway of where this patient is going to go to get that follow-up? It's also very important that we have a way to document these images, both in saving the image itself as well as having a documentation in the patient's chart of what your interpretation was and what you did about that image. And really focusing on, in these cases, that the primary goal of our POCUS is in using this for a diagnostic purpose, whether or not you can obtain the most pretty images for teaching purposes. That is, our priority is the image of adequate quality to make that critical diagnosis. And so this can be used in any algorithm. It's about asking the question, what decision is not able to be made based on the very limited assessment that you can do in your history and physical, and how can POCUS fill that gap to help us proceed on in our algorithm? What specific scan can we use, such as how we use our FAST exam in the trauma patient? And knowing what to do next, depending on what you see on that. This can be taught at the resident level, the advanced practitioner level, as well as across specialties, whether that's in a clinic setting or in the emergency department. POCUS can be used when POCUS is used intentionally, this can be very decision focused, does not take a lot of time, and does not add any additional burden on the provider. If you're bringing in the ultrasound machine with you when you're doing that initial history, using the ultrasound to ask very specific questions, you can expedite your workup as well as expedite your decision and disposition for these very critical patients. And with that, I want to thank my mentor, Dr. Capizano, as well as the Washington University Department of Emergency Ultrasound, and my mentors listed here.
Awesome. Thank you, Courtney. I have a question for you. I can foresee that in the community setting, when you are transferring to some of the big academic hospitals, that some of your transferring receiving doctors will say, what do you mean it's just a point of care ultrasound? What about the official ultrasound? Would you say to that, or what if you encounter feedback or resistance to your transfer because of that?
Yeah, so I've been in this exact scenario. The clinical sites that I currently work at are community hospitals with very limited specialty consultants. And what I say to that is we have the ability to upload our images into the PACS system that all of our specialists can see. And so I will encourage them to go and actually look at the images themselves. And I'm always more than happy to put the order in for the radiology performed ultrasound or the CT scan, but I want to initiate that acceptance and start working on the transfer and arranging the transport prior to getting that definitive imaging, because we don't need that to confirm that this patient needs a higher level of care, and they're more than welcome to get repeat imaging when the patient arrives at the destination facility.
I think that's a great way to tackle it. Having your images up in packs for people to see is important and just lends credibility to it. And thank you so much for your presentation.
Thank you.
Okay, we are going to move right along. Our next speaker is Dr. Heather Mulvik. Her mentor is Michael Gottlieb, and she is going to be speaking to us about engaging residents in quality assurance, an application of self-determination theory. So, Dr. Molvik, go ahead.
Yes, let me get you shared on the proper screen, not my Amazon Music screen. Come on. There we go. Okay. Hi, everyone. My name's Heather. I'm the ultrasound fellow at Columbia University, and you may have noticed a title change here. So initially it was Residence in Quality Assurance and Application of Self-Determination Theory, but after talking through it a little longer, the deeper question or answer that we're coming up with here is that maybe resident involvement in quality assurance just makes better attending. So let me jump into why I think that's the case. Okay, so today I want to talk to you about self-determination theory, what it is, why it's important, and how a perfect example of it is resident involvement in QA, and how I believe that through QA, we provide a foundation for doctors to become internally motivated to better themselves, become lifelong learners, and then those are the best doctors. I think we can all agree on that. So think about your attendings in practice. Typically, the model for motivating them to do something is this carrot and stick framework, where the carrot is some positive reinforcement, such as increased revenue, awards such as Ultrasound Goat of the Year, and the stick is this negative reinforcement, such as decreased revenue or reimbursement, unmet metrics, pestering emails if you have to write those. And this framework is an example of external motivation. And external motivation is problematic because, as you see here, studies show that if a person is driven primarily through external factors, the likelihood of sustainable change goes down over time. An example of this is exercising because someone just told you to do that, like you're a doctor, or maybe you want to lose 10 pounds for a wedding, versus internal motivation, where the likelihood of sustained change increases with time. An example of this is exercising because it brings you joy, it clears your mind. So while external rewards may get you started, internal motivation is what keeps you going. So you may be asking yourself, well, what alternative in medicine is there to the carrot and stick theory, which can be reframed to how can we develop internal motivation in our doctors? And that's where self-determination theory comes in. So SDT is widely recognized framework for understanding motivation and learning. So in summary, it states that each person has 3 core psychological needs. There's autonomy, which is feeling that the person is in control of their choice; competence, which is the person feels capable of doing the behavior; and then relatedness, where people feel connected to others when they're doing this behavior. And that when all 3 of these are met, we are developing internal motivation, which leads to curiosity, satisfaction, seeking mastery, which is what you would want in an attending. So how do we get there? QA, of course. So I bet that's the first thing that you thought of. But seriously, when we break it down, QA naturally fulfills all these needs within SDT. So residents can choose to be involved, and through the review of images, we consider the clinical decision-making choices and rationale. Was this scan documented correctly? Were there aspects that could have been improved? And that's autonomy. Through QA, residents are practicing their scans and receiving targeted feedback for improvement, which builds skills and confidence. That's competency. And through QA, residents spend time with ultrasound division, sharing the responsibility of ultrasound, involved in problem solving, hang sessions, discourse. This leads to attaining systems level fluency and confidence in leading safety and quality initiatives, and that is relatedness. So you may be thinking, this is a great theory, but what's this look more like in practice? So residents performing image review of their peers that teaches mastery of good image acquisition and communicating that. They can lead lectures in QA case presentations in the ultrasound conferences, or perhaps residency-wide didactics. And then QA also results in involvement in system changes. So residents I worked with during my training, not often, but well, actually, okay, yeah, often piloted new nerve block notes or templates and learned the behind the scenes of EHR development because of that. So to us, this theory and practice sounds great, but how do we get their buy-in from the residents? So potentially during the ACGME required ultrasound rotation, the topic could be broached. We can explain to them QA rapidly increases their learning at home, and you can see great cases you wouldn't otherwise get exposure to. It's a relatively low time burden, and you get relevant skills for all residents, not that just those that are going to fellowship. For example, oh no, there we go. My friend Jamari here, he went from our residency straight into an ultrasound leadership role at his shop because of all the experience he gained during our ultrasound track during residency. So how do we get the program leadership buy-in? Well, QA can fill the ACGME requirements in a non-checkboxy format, which residents can sometimes struggle to meet. These requirements are involving self-assessment and performance improvement, systems navigation, accountability, and ethical practice. And while in a community, this is all done in a community that supports them in building these skills, which may encourage the resident to stay in the program for either fellowship or a job after their graduation. So in summary, the problem is that our colleagues may not be using ultrasound in practice to the degree that they should. And one gap that is contributing to that is that they're not internally motivated to do so in this way. The solution I propose is involvement in QA as a resident, which builds internal motivation, which will ultimately make lifelong learners and better attendees. Here's a photo of some familiar faces of thoughtful, reflective, engaged attendings that I have had the pleasure of working with during fellowship, and my mentor Gottlieb that I photoshopped into the corner here. Thank you all for listening. Again, my name's Heather, and this is my email if you would like to contact me about this.
Thank you, Heather. That was a very engaging talk.
Thank
I think that for QA, we've actually talked about getting QA up for our residents. And I think when we initially broached that topic, the immediate first response from our residents was, what do you mean we have to do more paperwork and work? And I know that you touched on this in your presentation, but any additional tips that you can get for someone like me who is having some difficulty convincing the residents that this is good for their education and that this is something beneficial to them?
I think getting them involved in the nerdiness of the ultrasound division is the best way of motivating them. At least it worked for me. When people are showing the images of like, oh my gosh, have you seen this crazy find? And then you share that excitement of like that seeking, and you find discovery with them, and then they want to seek and discover these maybe fascinating cases. I think it's kind of maybe even like the jackpot model of like in gambling, what can stimulate them to keep going. Maybe
Yeah,
that's another theory we should interweave into here.
nothing better than jackpot. Yeah, I can see like some of our residents who are ultrasound inclined definitely favor QA, but some of them who have not no interest, but less paperwork, they're not focused on this stuff. It's tough. So, but
Mhm.
kudos to you for implementing and talking about it because I think it's just really important for everyone.
Thank you.
Okay. Thank you, Heather. We are moving on. Our next speaker is Dr. Philip Ayers. His mentor is Jordan Rupp, and he will be talking to us about Beyond Borders, building lasting impact in global ultrasound through collaboration, telemedicine, and AI. So, Philippe, you are
Perfect.
on. Go for it.
Thank you. Let me go ahead and share my screen. All right. So, hey everyone, my name is Felipe. I'm one of the ultrasound fellows at Denver Health. So, as it stands, 2/3 of the world's population has no access to ultrasound. So, not unlimited, not limited access, but no access. And for many of those patients, that gap is really the difference between a life-saving diagnosis and death. So today I want to talk about how we can actually do something about that and how we do it in a way that lasts long after we go home. So I'm sure we've all heard some version of the story. Imagine you're walking along a river and you spot a drowning child. You jump in and save them, but as you celebrate your success, you spot another one and then another. Our focus on rescuing the children prevents us from looking upstream. And as Desmond Tutu said, there comes a point where we need to stop pulling people out of the river and go find out why they're falling in the first place. So, shifting our mindset from saviorism to justice isn't just about diminishing the work of NGOs or the global north. Those efforts matter and they've saved countless lives. But we have to ask ourselves, are we creating lasting change? What happens when we leave? What happens when the donations dry up? So, even on the smaller scale of ultrasound implementation, these same questions apply. If we're going to go step into some other people's communities, the bare minimum is due diligence, understanding the cultural context, the needs, and the long-term consequences of our involvement. So our goal should not be to come in guns blazing, but rather as supporters who empower local heroes that are best positioned to create lasting change within their own communities. So with that in mind, let's dive into our global ultrasound journey. We'll start with the why expanding access to ultrasound matters. From there, we'll look at the real-world barriers to building durable programs, and then we'll shift to solutions. And finally, we'll bring it all together with an actionable framework. So, in a room full of emergency physicians, I don't need to convince you that POCUS is a powerful, life-saving tool, but its impact is even greater in resource-limited settings. So, in places like Tanzania, where CT, X-ray, MRI are limited or non-existent, POCUS becomes the primary and sometimes the only diagnostic imaging tool available. It isn't just convenient, it's the first step to preventing premature and preventable deaths. And to really understand how impactful it can be, consider this. Tanzania, for example, has one radiologist per 500,000 people, 10 times below the WHO benchmark. And there are only 30 public CT scanners in the entire country, concentrated in 3 national referral regions. So for 70% of Tanzanians living in rural areas, accessing one means traveling hours, sometimes days. And even near those centers, cost becomes the next wall. I watched families spend days pulling money from relatives just to afford a single scan. So this is where ultrasound changes that equation. A handheld ultrasound at the bedside requires no special room, no shielded suite, no radiologist down the hall. It costs a family next to nothing at the point of care. And suddenly that local provider has an answer and the ability to be a hero for their own patients in their own community. But, before we declare ultrasound the silver bullet, we do need to be honest about some of the barriers. So one of the biggest barriers facing global ultrasound is manpower. Tanzania, for example, has 140 physicians per million. The US has 3,000 per million. The WHO minimum is 1,000. So when there aren't enough providers to deliver basic care, building a sustainable ultrasound program becomes exponentially harder. The second is lack of training. Less than 5% of global ultrasound training sites are in Africa, and 81% of those are short courses, of which 40% are just one-off sessions. So these physicians get trained, they get a certificate, but then skills decline within a month, and then they never scan again. And then third is turnover. Many of these countries have high turnover rates. Tanzania has 56% of their medical graduates either leaving medicine altogether or immigrating to another country. So you invest months in someone, and within a year, they may be gone. And finally, and sometimes the most overlooked barrier is culture. So misconceptions about safety, gender dynamics, scope of practice hierarchies are real. So if you design your program around assumptions rather than the community's reality, you've already failed before you started. So these barriers are real, but we don't need to solve all of them at once, and you definitely don't need an army. The single most powerful thing you can do is find your 2 or 3 people, not a large cohort of residents, medical students that will eventually rotate out, but 2 or 3 individuals who light up when they hold the probe, who ask questions after the session ends, who are already thinking about how this fits into their practice. You're going to invest everything in them. Make them the ultrasound authority in their community, because when you fly home, they don't go anywhere. They become your boots on the ground, your partners. And that's how you address manpower turnover. That's how a short-term visit becomes a long-term program. So this is the train the trainer model. You train 2 to 4 locals, they become the authority, and they start the domino effect. One visit becomes 10 trainers, 10 trainers becomes 100 providers, 100 providers becomes a community where ultrasound just exists, sustainably, independently, without you. But how does technology play into this? So for me, it's what allows the train-the-trainer model to actually work between visits. And the two tools I found most valuable are tele-ultrasound and AI. So once you have your local heroes in place, telemedicine keeps the program alive, especially in that first year. Think about what it's actually solving. Your provider's at the bedside, they're unsure of what they're seeing, and without telemedicine, that moment ends in uncertainty. But with it, they pull out their phone, and within minutes, you're watching the screen together in real time and working through those findings together. Now, maybe you're thinking, aren't these platforms expensive? And yeah, some of them are. But in Tanzania, teleultrasound mentorship is already happening over WhatsApp. It's free, runs on 3G, and is already on everyone's phone. So no IT department, no budget line, no enterprise contract needed. It just requires a relationship, which you've already built. And as the program grows, you'll be able to invest in more structured tools. But the platform doesn't matter if the relationship isn't there. So start with WhatsApp and build the system around the people, not the software. And here's a real case example. One of our providers called me about a pericardial fusion, and something wasn't right with how the heart was moving. Over the phone, we obtained mitral inflow variation, which was abnormal. We then worked through RV diastolic collapse, confirming what the mitral inflow was already telling us. This wasn't just an effusion, this was tamponade. So with teleultrasound, they knew what the next steps were to do. They performed a pericardiocentesis and the patient survived. So that's telemedicine working exactly as it should, not replacing the provider, but building on the foundation you laid while you were there. And how does AI fit into this? So if telemedicine is the bridge between visits, AI can keep the program running when nobody's available to call. So there are many AI tools out there, but I'm going to report 3 that I used. So the first one is self-reporting AI. Platforms like ScanHub Sage AI, what it does, it reviews submitted clips, scores image quality, flags missing views, and generates structured feedback. No mentor required. So you have a provider thousands of miles away. They submit 10 scans on Friday, and by Saturday, they have detailed feedback on each one. Another is AI-guided image quality and labeling. So this was really beneficial when we first started teaching the providers how to use ultrasound. So by having an AI tool that can label structures, score image quality, and guide probe position helps fasten the education of the providers. So a novice user with a 2-day course can self-correct even when a provider isn't in the room. And third is AI self-tool measurements. So an example is Butterfly's FDA-cleared gestational age tool. Just 3 steps under 2 minutes, no biometric training required, and this has already been shown to be validated across sub-Saharan Africa. So this is not the future, right? These tools are available today, and AI can help fill the gaps between visits to keep the program moving and the skills sharp so that you don't have to get on a plane every month or so. So you've maybe gotten impatient listening to me talk like Robbie, asking me, what's the actual plan? How does this all translate into something structured and actionable? So when we're looking at a long-term impact, we're looking at 3 major phases. So our phase 1 happens during your visit. So during that time, you're going to find your champions, train them, co-develop the curriculum in language and in cultural context, establish baseline competency milestones, and also set up your shared case library and communication plan before you leave. Phase 2 is months 1 through 6, and this really is the critical window. So this is where you have your weekly tele-ultrasound mentorship calls, your weekly QA and online didactics, outcome tracking, and contingency planning if the machine starts to not work correctly. This is where that relationship will either hold or it doesn't. And then finally, phase 3, once you've made it this far, really becomes more of a monitoring phase. Your local champions are now leading. You've taken the back seat, and your role shifts more to securing funding and building the evidence base. The program will itself revise curriculum annually, and it expands regionally through the train-the-trainer model. So the key to all of this is that you plan your exit strategy even before you arrive. And one final note in terms of building a sustainable program is give your learners a tangible endpoint. So a certificate like we created for Bugando Medical Center, issued by the local institution, not by you or our own institution, it signals that this is a real program with real standards. It provides something as a point for career advancement and retention. So when it comes from their own institution, it helps build the local ownership you need to actually get the program to survive and keep going. So I'll just leave you with this. three big points is that you go to build capacity, not to demonstrate yours. You use technology relentlessly between your visits to keep it alive. And you'll measure the program success not by what happens when you're there, but what happens when you're not there. And lastly, sustainable change is not something you do for a community. It's something you build together and then you step back away from. Thanks. And I'd also like to thank Jordan Roop for all his mentorship during this.
Thank you, Felipe. Those were important, excellent talks, excellent points. I think that the thing about global health that's tricky is not that there isn't a need. I think there's definitely a demonstrated need, as you pointed out in your presentation, that global health is just so important. I think it's harder to convince your department to offer funding for you to fly somewhere that's not your department, somewhere that's not even in your country, and provide this necessary, important care to people, to train people that won't benefit your department at all necessarily. I think that's one of the big barriers. And what do you think can be said in response to that? To just let people know, hey, like this is something that we should be supporting, and yes, I should be getting protected time and money and buy out for this.
So I think one is about creating partnerships. So for example, my previous residency where we established our contact with Tanzania is that it might not benefit the hospital directly, but by having rotations between the residents in Tanzania come to New York and then us go there, it creates a new relationship that builds a greater horizon. So for my hospital, they saw that as a benefit, being able to train the EM residents in a completely new environment. So I think pitching it as a way that this improves your resident quality training and not just those in Tanzania is a great way to actually get the ball rolling.
Thank you. And I wish you luck wherever you go in the rest of your fellowship and bringing your global health to all the places that need it.
Thanks.
All right, and we're going to move on. After this next presentation, we're going to take about a 10-minute intermission so that we can all use the bathroom and sip some coffee or water. So last but not least, for the first half, we have Dr. O-Chan Kwan. His mentor is Curtis Su, and he will be speaking to us about MEAT models, a high-fidelity approach to ultrasound-guided nerve block education. So, O-Chan, you can go on ahead.
Hello, everyone. I'm just going to set up my slides quickly. Can everyone see my slides?
Yes, we see your slides. We do not see your presenter view.
Great, great. Well, my name is O-Chan Kwan. I'm a ultrasound fellow at the Maimonides Medical Center. So as we all know, ultrasound guided nerve blocks are they've revolutionized pain management in the emergency department. It not only provides targeted pain relief, it also avoids the risks of very systemic analgesics. MEAT models are not only affordable, they're super easy to make. It's a great educational tool that can accurately mimic a huge variety of different nerve blocks. And through my experience in the Emerald Ultrasound Committee as an ultrasound fellow at Maimonides, I've been fortunate enough to make a lot of different MEAT models for educational nerve block workshops. So I'm hoping through this talk that many programs will be able to do the same. So first off, welcome to the bustling kitchen of this new restaurant, Nerve Block, where we serve injured customers the highest quality MEAT models and nerve blocks. So today, I'm going to go over the ingredients list for each nerve block, and also I'll be covering how to make MEAT models for each of these 4 nerve blocks. So first, all chefs know that the key to preparation is getting all your ingredients ready. And you'll find that most of these ingredients are very affordable. The pork tenderloin, you can find at most meat markets. They come in a very cylindrical shape, which is convenient for making these meat models. And when you buy them, you want to make sure they already have a fascial layer on top. As you can see here on the right, the tissue looks remarkably similar to human tissue, and you can actually see a very bright fascial layer with the fascial layer still attached to the meat. Next is yarn. When it's soaked with gel, it looks very similar to nerves on ultrasound. It's important to be able to squeeze the yarn to make sure all the trapped air is squeezed out of it. On the right here is an example of a peripheral forearm block model of a median nerve. This yarn looks very similar to the median nerve in both short and long axis. It even has a fascicular pad in the long axis here. One tip is that you can twist several strands of yarn together to form even thicker nerves. Next, we can use straws that are filled with ultrasound gel, and this looks very similar to vessels on ultrasound. You want to be able to include both ends with already chewed gum, and you can use different size straws to represent different sizes of vessels. For example, here on the right is a femoral nerve block model, and you can see here this large boba straw represents a femoral artery. Another tip is that this gel-filled straws can actually represent nerves too on an interscalene block, which I'll present on a later slide. The next ingredient is meat glue. This is basically a powdered enzyme that helps stick meat layers together. So when meat handling the powder, you want to make sure to protect yourself, wear gloves and a mask. You sprinkle the meat glue in a very light layer and also evenly over each meat layer. And what the meat glue does, it helps brighten up the fascial plane here on ultrasound. It also helps us use multiple hydrodissection injections with the same meat model because the meat sticks together better. And here's some clips of an actual fascial plane with the meat model. On the left here is an incorrect needle placement intramuscularly, and on the right you can see a great hydrodissection when the needle is correctly placed within that fascial plane. So our restaurant's finally open for our first customer. Our first customer of the day climbed a tree to save a stranded cat, but she unfortunately fell. She broke her femur, but was also found to have an incidental anterior thigh abscess. So we decided to serve this customer a fascia iliaca plane block, which provides analgesia for the thigh by targeting the femoral nerve, the lateral femoral cutaneous nerves, and also the obturator nerve. So to prepare this meat model, you will need 3 different cuts of meat. One is a cylindrical piece of meat representing the iliopsoas muscle, and then 2 flatter pieces of meat representing the fascia iliaca and the fascia lata. So first, you just place a gel-soaked yarn right across longitudinally across the cylindrical piece of meat, which is the femoral nerve and the iliopsoas here. The next step is placing a thin layer of meat right on top, representing the fascia iliaca and serratus muscle. Next, you place a large boba-filled straw representing the femoral artery, making sure it's adjacent to where the yarn was placed below it. And the third layer of meat is the fascia lata that you place right on top. And this is what the completed model looks like here. And you can see what this meat model looks like on ultrasound. It looks pretty similar to a real fascia iliaca block here on the left and also this illustrated diagram. The landmarks you're looking for are the fascia lata, the fascia iliaca, the femoral nerve, the femoral artery, the iliopsoas muscle, and the sartorius muscle here. And this is what the ultrasound clip looks like when you're doing a hydrodissection into the actual fascia iliaca plane on meat model here. It looks great. Our next customer is actually the brother of the first customer. He tried to save that same cat by climbing that same tree. He also fell, causing a shoulder dislocation and a proximal humerus fracture. So we decided to serve him an interscalene block, which is a brachial plexus block affecting the C5 through C7 nerve roots. So this allows for regional analgesia to the proximal humerus and also paresis to the shoulder muscles, making it ideal for reducing dislocated shoulders. To prepare this model, you will need 3 different cuts of meat. So first, you have 2 halves of a cylindrical piece of meat representing each scalene muscle, and then also a thinner wedge-shaped piece of meat representing the sternocleidomastoid muscle. So first, along the outer edge of the anterior scalene cylindrical half, you will make a long lengthwise incision, and within that incision, you'll place a large boba-filled straw representing the carotid artery. On the second half of the scalene muscle, you'll place 3 smaller adjacent straws representing the 3 nerves of the brachial plexus. You'll simply then sandwich those 3 straws between the 2 scalene muscles here. And then over top of this model, you'll place the wedge-shaped SCM muscle right on top. And this is what the completed meat model looks like. Here we can see what the meat model looks like on ultrasound. You can see that great traffic light sign created by the C5, C6, C7 nerve roots, or the straws in this case. And the anatomy we look for is the anterior scalene muscle, the middle scalene muscle. And here on this clip, you can see live needle guidance towards the brachial plexus with an injection just adjacent to that brachial plexus next to the medial scalene muscle. The third customer is a firefighter who arrived at the same scene. He tried to use a ladder to save this poor cat, but he also fell. He broke his anterior ribs. He was also incidentally found to have a big zoster rash on the same side of his chest. So we decided to serve this customer a serratus anterior block. This is a fascial plane block which targets the lateral cutaneous branches of the thoracic intercostal nerves, and also so what helps provide analgesia to the anterior lateral chest wall specifically. So to prepare this, you need 3 different cuts of meat. You will need a rack of ribs here, the ribs and the intercostal muscle right in between, and also 2 thinner layers of meat representing the serratus muscle and the latissimus dorsi muscle on top. So this is a pretty simple block to make. The bottom row is the rack of ribs representing the ribs and the intercostal muscle. The second row is the serratus anterior muscle. The third layer of meat is simply just placed on top. That's the latissimus dorsi muscle, and this is what the completed model looks like. On ultrasound, we can see the anatomy here. The top layer is the latissimus. The second layer is the serratus. The third layer, the rack of meat, is the ribs and the intercostal muscle in between. And we can actually see a needle being placed within that target area between the serratus and latissimus dorsi, which is the target area for this block. And this is what it looks like on ultrasound. We can see a nice hydrodissection between the serratus and latissimus dorsi layers. One tip is that the needle can also be placed downwards right on top of that rib, which is another potential target for the serratus anterior block. The last customer of the day is the mother of the firefighter who happened to be on scene. She saw her son fall from the ladder. She collapsed in shock. So she came to our restaurant with really bad back pain, but she was found to have a big obstructing stone causing a lot of renal colic. So we gave her an erector spinae plane block. So this is a truncal plane block that targets the branches from the spinal nerve, including dorsal rami, which helps alleviate the back pain, but also the visceral afferent nerves, which helps alleviate visceral pain from things like renal colic, pancreatitis, appendicitis. The cuts of meat you will need is just two. You'll ask the butcher to give you a rack of ribs, but to leave the spinal vertebrae attached. So this conveniently gives you the transverse process, the posterior ribs here, and also the top layer of meat that's already attached to the ribs will represent the ESP muscle. The second layer of meat will be the trapezius and rhomboid muscle right on top. So all you do is place that thin layer of meat right on top of this rack of ribs, and this is what the completed model looks like. On ultrasound, this is what the anatomy looks like. Here we can see that flat transverse process, the ESP layer that's already attached, and the top layer of muscle representing the rhomboid and trapezius muscles. For a real ESP block, what we typically do to confirm the location of the transverse process is by first locating the rounded surface of the posterior ribs and then tracking that medially to the more flat surface of the transverse process. And this meat model allows us to do the same. So this is a clip, the rounded rib that transitions down to the flatter transverse process. And on this clip here, we can see actual needle injections into that transverse, or right above that transverse process, lifting up the ESP muscle above it. So now our restaurant's closed, all of our customers left happy and pain-free. So why meat models specifically? Other cheaper alternatives like tofu or konnyaku jelly, they're very fragile and deteriorate only after a couple uses. In comparison, meat models, they can be used for multiple repeat injections, even over multiple workshops, and they can actually be frozen and defrosted for future uses. Cadavers are great for realistic training, however, obviously very expensive to maintain, and they're rarely accessible. Meat models are much more affordable and widely available as long as you have a grocery store to buy the meat. And third, the meat models give a very realistic appearance in ultrasound. Not only does it look like human muscle, it provides the opportunity to do dynamic needle guidance and also actually practice hydrodissection on actual models. And then lastly, last but not least, these models are very easy to make with accessible ingredients. And as the famous chef Cousteau said from Disney's Ratatouille, anyone can cook. I truly believe that as long as the institution can make these meat models, they can definitely teach anyone how to perform these nerve blocks correctly. I do want to mention that I was only able to teach about 4 different meat models in this lecture, but remember, you can pretty much make meat models for any type of nerve block out there. At Maimonides, we host a regional course every year called Block Camp, where we make and teach our nerve blocks using meat models. And these are pictures just from a couple of days ago. Here I am on the right. So from the last 2 years, we've done pre and post intervention surveys, which have already shown that this one-day course can effectively teach nerve blocks using meat models and also improve knowledge retention over 90 days. And a future direction will be to create an open access website where we include free images, instructive videos, and step-by-step instructions on how to create these meat models. These are my references. I'd like to thank my mentor, Dr. Curtis Xu, everyone from the symposium who was able to make this possible. Thank you very much.
God, I love Ratatouille. What a great movie.
Same here.
So Ochan, thank you so much for your presentation. That was really good. In the experience that I've had with meat models, I've not been able to really freeze, or I've been able to refrigerate them, but not really freeze them. And after a couple of days in the fridge, they tend to get a little smelly. Is there anything else that you do for the meat model to help preserve it for longer without destroying the quality of the meat?
So for the block camp, we have 2 days right next to each other. So we don't freeze the models if they're going to be used over a course of a few days. We refrigerate them. Obviously, the smell is pungent, but they still are able to be used pretty well after that second day. And then if we freeze it, I've found that defrosting it can last for months, and it still looks pretty well. We actually have a set ready for our next conference coming up later this month. So those are already made. Those are already made.
Delicious. I hope you get a chance to eat the meat afterwards.
The leftover meat, yeah.
Yum, fellow opportunity. So thank you to all of our speakers in our first half. We are going to take a brief 10-minute intermission. I have on my time, it's 5:16. So why don't we all aim to get back at 5:26? Let's take a bathroom break and such, and we will pick things up from there. And again, thank you everybody for showing up, and we'll be back in 10 minutes. Okay, I'm going to give everybody about 30 seconds to a minute to get back on. It's 5:25. Hopefully you all enjoyed your nice coffee bathroom break and such. And I'm going to wait for all of our judges to get back before we pick it back up again. Okay. Okay, looks like we're just waiting for Mira. So Mira, if you're back on ready to judge, just give me the go ahead and I will pick it back up. There you are. What's up? Thank you guys again for staying and we're just going to keep on going on. So, starting our second half, we have Dr. Jeannie Kwong Win. His mentor is Michael Donta, and she's going to be lecturing to us about the dreaded common bile duct CVD. So go ahead.
Hi guys. All right, let me try to share the screen.
All right, we hear you. And
Do you guys see?
we see slides, not presenter mode. We see slides.
Perfect.
Go on
Let's
ahead.
begin. Hi, I'm Dr. Jeannie Kong Nguyen. I'm currently a fellow at Kendall Hospital in Miami, and we're going to discuss where is the dreaded CVD. So let's begin with the case. We have a 46-year-old woman. She's coming to the ED for right upper quadrant pain that has been going on for the past 4 days. You do a physical exam, and she's tender right in that right upper quadrant. Now, many of us will already have the machine in there, and you start performing the upper quadrant. But then you get to the final part of your right upper quadrant, the CBD, and you try, and you might just immediately give up, or you don't even try. I know I did that as a resident, and I know as I was preparing for this presentation and doing reviews of scans, my residents have been doing this. So let's figure out how to find that common bile duct. Now, with any ultrasound, we have to have a great understanding of anatomy. As you know, the gallbladder is a elongated pear-shaped organ that is located just beneath that liver. That gallbladder tapers into the neck, which tapers into the cystic duct. That cystic duct is combined with that common hepatic duct to form the common bile duct. And that common bile duct is part of a portal triad that we know of as the portal vein and hepatic artery with the common bile duct. And now that we understand the anatomy, the next part is just getting to scan. Now, there are 3 main approaches to finding the gallbladder. You have the subcostal sweep, the X7 approach, and you have the axillary transhepatic approach. Now, I know some people have a preference on where they start, but I kind of just go through all of these because everybody's anatomy is different. You kind of want to optimize your view. So this is what the subcostal sweep looks like, just as it's said. You kind of sweep that subcostal area of the patient. Now, in this presentation, you can see that the probe is more in a horizontal view. Ideally, also, you can go in, that probe can be in more sagittal view. The X7 or the xiphoid 7 approach is essentially you find that xiphoid, you go over approximately 7 centimeters to the right, you just prop that probe in a horizontal, kind of get in between those ribs, and your gallbladder should be just right below that liver. And the final approach that I like is the transhepatic axillary approach. It's almost like you're doing a fast. You're kind of using that liver and trying to find that gallbladder. Again, you can have that probe. You might have to rotate it in order to optimize your view of that gallbladder. Now that you kind of know how to find a gallbladder, let's go into some anatomical landmarks to help you find the CVD. So the first thing you need to know are that we have a lot of signs that we know about. The first one is the exclamation point sign. Exactly what it sounds like. It looks like an exclamation point, which is composed of that gallbladder in long view, and it kind of tapers into this hyperechoic line that we know as the main lobar fissure, and now that we're calling it the sonographic cystic pedicle, and it leads into the portal triad, which is another sign. So here are some examples of what that looks like. Again, just that gallbladder, you have that hyperechoic line, and you get into that portal triad. Now, part of the exclamation point includes another sign that we are very familiar with. It is going to be a structure that you can see kind of pop into view in this video, and that is the Mickey Mouse sign. So the Mickey Mouse sign, exactly what it sounds like. It looks like Mickey Mouse. You have the portal triad. That common bile duct and the hepatic artery is going to lie just anterior to your portal vein. And usually that common bile duct is going to be lateral. However, because everybody's body is different, you might just have to put some color on there to kind of figure out if you're looking at the common bile duct or you're looking at a vascular structure. So again, another representation of what that might look like. And here is a video captured by one of the residents, they're finding that exclamation point and then that Mickey Mouse sign at the very end. So switching gears a bit, we are familiar with the exclamation point and the Mickey Mouse, but some of my residents and med students are not familiar with the next sign, which is a double barrel shotgun sign. Those of you who are not familiar with guns might be like, what is that? But here is a representation of what that looks like exactly. You kind of have like two vascular looking just anechoic structures sitting on top of each other. Now this sign is actually for when you have a dilated common bile duct sitting on top of the portal vein, but understanding the sign also helps you find the common bile duct when it is normal. So in this example, you see we have a gallbladder. There's some stones in there. But then at the very end of the gallbladder, you see there are two anechoic structures kind of like sitting. There's one smaller one and sitting on top of another one. And you're like, what is that? What could that be? So then you decide to put some color on there. And you see that there's color on the structure just below this other smaller structure. And that's exactly what we're looking for. We're looking for that common bile duct, and that common bile duct is sitting right above that portal vein. So this goes into our another point. So when you're ever in doubt, use color Doppler. It's going to help you figure out if you're looking at a vascular structure versus that common bile duct. So here are some examples where color actually was really useful in finding that common bile duct and distinguishing. And then obviously it's useful, as I talked about, when you're looking at the Mickey Mouse sign as well. Again, here is the representation of what that double shotgun barrel sign is. So you actually have the dilatation of that common bile duct. In this image, you have a stone in there, and then that portal vein is sitting just below. So let's go back to our case of this 46-year-old woman. You basically find out that she also has elevated transaminase and bilirubin level. So let's say you do an ultrasound, you find the common bile duct, but this is the image that you're getting. And then this is the image with color. So you're thinking, what is this? Like, what am I looking at? This goes into another sign that we might be familiar with, which is the olive sandwich sign. It's kind of weird, but I was able to find an olive sandwich on the internet. So this sign is actually choledocholithiasis. You have a dilated CBD, and then you have this smaller structure, which is the oval hepatic artery, and then you have your portal vein. So it's just literally looks like a sandwich. So back to the case, you have that dilated CBD, which is that asterisk. That arrow is pointing to the hepatic artery, and right below it is the portal vein. So now that you understand the signs and you understand anatomy, what if you're doing the scan, you still can't find the CBD? Well, maybe you need a repeat residency, and in my case, I think I would have to do another fellowship. But in all seriousness, do I need to even find the common bile duct? Well, a lot of articles actually call into question whether or not we need to find the common bile duct. So there was a prospective observational study of 158 patients. Basically, they found that none of those patients there were no isolated common bile duct isolation in the absence of abnormal or other ultrasound findings that would suggest like a cholecystitis or a choledochia. And then in another study, there was a retrospective chart review where they looked over 2 separate EDs in 10 years to kind of determine the prevalence of an isolated common bile duct in cholecystitis or in choledochia without any abnormal labs. And again, that prevalence in that study was less than 1%. So, in summary of those articles, CBD dilatation on its own is pretty rare. But if you're not looking for the common bile duct, you might miss out on finding pathology such as, your choledochia or maybe your cholecystitis. So in summary, how do you find the common bile duct? You find the gallbladder in a long view. You follow it to the hyperechoic main lobar fissure or sonographic cystic pedicle until you reach the portal triad. So that gives you the exclamation point sign and also your Mickey Mouse. And then you should be familiar with a double shotgun barrel sign. And you should also be familiar with the olive sandwich sign. So hopefully that helps you in finding the common bile duct. Thank you, guys.
Thank you so much, Jeannie. That was a great presentation. I guess for us in looking at the CBD, I feel like my residency kind of matched where you're currently doing fellowship in that if I didn't find the common bile duct as part of my biliary scan, my ultrasound director would strike the scan down and tell me that in fact I did not do a good job. In fellowship, we adopted a more laissez-faire version of it of, if you have a normal gallbladder, you don't really need to find the CBD. And now I work in a place where it's kind of like in between. So for you guys, are you mandating that everyone is getting a CBD in your biliary scan where you currently work? And is that something as you finish out your fellowship, will you require the CBD in your future scans for your residents, fellows, APs, co-attendings?
Honestly, based on just going through so many scans in this past couple of weeks, finding images, a lot of my residents skip even trying to clip them trying to find it. So I do think there's something to be said about knowing your basics and just understanding that anatomy and even being comfortable finding something that is hard to find, because honestly, those skills actually transfer into skills of other applications in ultrasound.
Awesome. Hey, thank you again for the talk. And we are going to move right along. Our next presenter is Dr. Lachlan Driver. His mentor is Matthew Racinti. And he has a very interesting topic. He's going to be telling us about why we should not be doing nerve blocks in the emergency department. So Lachlan, you can feel free to take it away.
Perfect. Can you see my slides okay?
I can see your slides. I can hear you. There's a little bit of a glare in your camera. I don't know.
1 second. Let me fix it.
All right. Yeah. It was like your shirt was brightly glowing in the camera, and it was nice. It gave you a very
nice glow.
Holy Zen. That's better. Yeah. It took away your holiness, but maybe never mind.
I was going to say, make it sound like a bad thing.
Lord. Please, please continue.
Thank you, Dr. Shea. Yes, my name is Lachlan. I'm the ultrasound fellow at Brown this year, and my mentor is Dr. Matt Racinti from Denver. And I'm going to start with a bold proposal. Maybe we should stop doing nerve blocks in the emergency department. And this is not because they don't work. They absolutely do. That's almost the problem. They work so well that they tempt us into imagining the ED has time, space, equipment, and emotional stability. A place where the ultrasound is charged, the block needle is easy to find, and nobody yells, "Doctor, STEMI coming in," as soon as the exact second you put on sterile gloves. So for the next few minutes, I want to make the case against them, or really against the way our systems make them harder than they should be. So, to make sure this is not just me gaslighting myself, I did what any serious academic would do. I went to Reddit, which, to be clear, is not peer review. It is more like vibes-based medicine with better memes. But the comments were actually quite revealing. The same themes came up again and again. Not that blocks don't work, not that pain does not matter. It was this: the emergency department makes blocks hard to do reliably. And that is actually an important distinction because it means the problem may not be the procedure, the problem may be the system around it. The first barrier very commonly cited was time. A nerve block is not necessarily difficult, but it does require a small pocket of uninterrupted reality. And the ED is not exactly famous for that. You can have the best intentions in the world. You can say, I'm going to do this fasciitis block for this hip fracture. And immediately the department says, oh, that is adorable. Also, room 12 is hypotensive, triage needs a stroke eval, radiology's calling, and somebody wants to leave AMA. So instead, we reach for what is fast and familiar. Morphine, Dilaudid, the tools that already fit into our busy lives. That does not mean they're any better. It means they're easier to deploy when the department is on fire. The second barrier is logistics. A block is a procedure, and procedures require stuff. Needle, probe cover, chlorhexidine, sterile gel, local tubing, and ideally an ultrasound machine that is available, charged, and not currently being used as a desk. A lot of people are not avoiding blocks because they don't care about pain. They're avoiding them because the ED turns a 5-minute intervention into a whole scavenger hunt. This was one of the loudest Reddit themes. I'd do it if I could actually get what I needed quickly. If you've ever confidently said, I'm going to do a block, and then spend the next 7 minutes opening drawers like you're trapped in an escape room, you know exactly what I mean. The third barrier is fear. Even when complication rates are low, the emotional weight of rare complications is huge. Last nerve injury, hitting the wrong structure, failing after taking the time you didn't have to spare to begin with. And this is when human psychology matters. We like to think that we make decisions based on probability, but that's not really how any of us work. We remember stories, not spreadsheets, or remember the scary case, not the denominator. So even when the evidence says blocks are safe, the emotional experience of rare but catastrophic can still push people away from doing them. The fourth barrier is training. Some clinicians learn blocks early and often. Others learn one block once on an ideal patient in a quiet room with an expert standing beside them. Then they step into a real ED. The patient is larger, the anatomy is deeper, the room is loud, the patient can't position, and suddenly your confidence disappears. In high-pressure environments, people do not default to what they admire, they default to what we have practiced. And if we practice opioids and sedation far more than blocks, that is what we will reach for when things get busy. The fifth barrier is culture. In some departments, blocks are normal. In others, they're treated like a niche hobby, like sourdough and plants. Like, oh, like, that's so cute, you and your little ultrasound project. And cultures matters more than we like to admit. If it's not the norm, it feels extra. If the department norm is sedation and opioids, then doing a block can feel like volunteering for more work, more documentation, more reassessment, more coordination, more explaining. So blocks start to feel optional or even inconvenient instead of the standard of care like they should be. And once that happens, the easiest path wins because in AD, the path of least resistance usually does. So yes, time pressure, equipment issues, fear, uneven training, workflow friction, culture make a pretty convincing case that maybe we should not do nerve blocks in the AD. Except none of those are actually arguments against nerve blocks. They are arguments against an emergency department system that makes the best care the hardest care. Because once we see the problem clearly, the answer is no longer convince individual doctors to just try harder. The answer is to redesign the system. Because when nerve blocks work, they do more than lower a pain score. They can reduce opioid use, avoid deep sedation, and make imaging or procedures like fracture reduction easier. They improve comfort, decrease agitation, and can sometimes change the course of the entire hospital stay. And pain is not just a symptom. It has downstream effects, makes care harder, and shapes how patients experience the ED. And nerve blocks feel different because they're precise and patient-centered. So if the real barrier is friction and time, how do we fix that? We stop treating nerve blocks like optional personal skills and start treating them like a system. The first barrier is time. I would argue that time is not wasted. It is redirected to higher value care. We already invest time teaching and performing procedures like central lines, arterial lines that can often be completed outside the ED. They can be done in the ICU. Regional anesthesia belongs in the same category. It's a skill that improves care, even if it takes a few extra minutes up front. And effective analgesia is not a luxury, and nerve blocks are not luxury procedures. If we value procedures that stabilize patients, we should also value procedures that meaningfully treat pain. But the bottom line is, when inevitably it is my time on that stretcher with a broken hip, I'd want the block to be done for me. The second barrier is logistics. And how do we tackle that? That means having a short menu, not every nerve in the human body, just a few high-yield blocks that cover common painful presentations, fasciaca, interscalene, transgluteal forearm, pangs, maybe some others. It means every ED having standardized kits, one place, one setup, easy access. And I can't overstate the importance of how much easier it is just to grab a box, walk into a room, consent the patient, and just start the procedure. It also means cognitive offloading, having weight-based dosing cards, checklists, safety reminders, rescue plans on top of our kits. And the third barrier is fear. Even when complication rates are low, the emotional weight of rare complications is huge. But we are not doing these procedures alone anymore. We have ultrasound, we have better training, we have growing evidence, and we have colleagues that teach and support each other. So maybe the goal is not to eliminate fear completely. Maybe it's just to stop letting fear make the decision for us. And we know that we are very well supported. ACEP says that regional anesthesia is a core component to control pain in the ED. This JAMA Open article show blocks reduce delirium. This extensive Cochrane review shows that they lessen pain and reduce time to mobilization. And this JAMA Open article shows that they have an exceedingly low complication rate. Not to mention that all of these different orthopedic societies saying that this is a grade 1 recommendations for their patients to receive nerve blocks. For culture, we need to make it a team sport. This means realistic practice and training, not just perfect patients in perfect settings, but practice under actual ED conditions. And it means buy-in from nursing, pharmacy, ortho, and the department as a whole. Because once blocks become team supported, they stop feeling extra and they become the default. I have a choice. I can spend hours every single time arguing whether a patient needs a block before ultimately deciding to do it anyway, or I can work to reduce the friction so departmental policies can make every one of those interactions easier for myself and my colleagues. Because once blocks become team supported, they stop feeling extra and they become the path of least resistance. And that's the whole game. In the emergency department, we don't always do what we believe is best. We do what the system makes easiest for us. Pain in ED gets compressed into short encounters and busy workflows. Nerve blocks give us another way to treat that pain. And the biggest barriers are usually not technical, they're systemic. Time, workflow, training, equipment, culture, that's the friction. So next time you're standing at the bedside with a patient in severe pain, maybe the question is not just, can I do a nerve block? Maybe it is also, what is getting in my way? So as ultrasound leaders, we need to do better to reduce the friction systemically, because if we want nerve blocks to become routine in the ED, we need to make them not just easier to learn, but also easier to set up and easier to integrate into clinical care. At the end of the day, it's not just about doing something fancy with ultrasound, it's about treating pain and making the right thing easier to do. And we need to make our own system work for us. So we should do nerve blocks in AD, we just need to make them the path of least resistance. Thank you, everyone.
Thank you, Dr. Driver. That was wonderful. Um, I don't know how much we are going to be able to change the system anytime soon, sad to say, but you made a convincing argument. Um, I think for us, if we work in a system that is not really changeable, what do you made some excellent recommendations for all of us. Which of those do you think is most notable, or which ones would you recommend be implemented first or even second?
Oh yeah, great question. And I think this is like also from personal experience working at different hospitals. The hospitals where we have nerve block kits and order sets and protocols and also kind of departmental agreements it's so much easier to get these done, because if I have to notify ortho and wait for them to see the patient, et cetera, as opposed to now all I have to do is tell them I'm doing a block and we're allowed to, just do the block. And also I would say having nerve block kits available is such an important thing, because if I feel like I'm a raccoon, like looking through drawers, trying to find all the things. I have to bring my own nerve block needles to some of the hospitals, and it just makes it so much difficult. And I can teach every single intern this block 50 times, but if it's not easy for them and if they don't continue to use it, sometimes I wonder what the point is.
we used to force our residents to make their own nerve block hits, but maybe we should look into that. So thank you again, Dr. Driver. That was lovely. As we move on, our next presenter is Dr. Nicole Sales. She unfortunately could not make it here today. She is currently on vacation in Olympic National Park in the Pacific Northwest, and she has informed me that there is very, very poor Wi-Fi. So in lieu of that, she has sent a video recording in. So I wanted to introduce her video recording. This is Dr. Nicole Sales. Her mentor is Mike Jones, and she's going to be talking to us about a transgluteal sciatic nerve block versus hydrodissection, and I hope that she is doing well up in Pacific Northwest. And hopefully this plays.
Hi, everybody. My name is Nicole Sales. I'm an emergency medicine ultrasound fellow at UConn Health and Hartford Hospital. Thanks for allowing me to join you all pre-recorded today. Today, I'm going to talk to you about to block or not to block the transgluteal sciatic nerve block versus hydrodissection. So, quick introduction, sciatica is a very common complaint that we all see in the emergency department. And the transgluteal sciatic nerve block has been shown to be an effective and safe pain control method for patients with acute sciatica in the emergency department. There is a risk for adverse effects in this particular nerve block, mostly the concern for motor blockade causing foot drop, which typically is transient in nature, but obviously has an increased risk of falls. So there is another kind of alternative option, which is hydrodissection, which has been a proposed alternative to kind of mitigate the risk of the motor blockade. This was first kind of thought of applying into the emergency department after being used in the outpatient setting for other compressive neuropathies for things like carpal tunnel. So the indications for either the nerve block or the hydrodissection would be to limit or prevent the need for medications with negative side effect profiles. So anything like opioids, even NSAIDs or muscle relaxers that potentially can cause patients harm, especially in the elderly population, causing increased risk of falls, confusion, anybody with renal dysfunction, things that we might want to avoid. This would be a great alternative to those medications. Also, the obvious of anybody with radiculopathy down unilateral or bilateral legs. We typically think of sciatica down one leg, but we'll talk about a recent case report recently that showed the treatment of bilateral sciatica with these particular procedures. And then anybody with refractory pain to traditional medication management. So this is going to be patients who either came in from the outpatient setting after failing outpatient treatment, or patients who are already in the ER who received IV, IM, or oral medications that are still not having good pain control. This would be a great option as kind of the next step to determine if this patient maybe can go home or needs further intervention. So general technique for both the nerve block and the hydrodissection, the patient's going to be in the left or right lateral recumbent position with the affected side facing up. They're going to be facing away from you, and you're going to have your standard nerve block setup. And then this is going to be the approach with your needle. So like most nerve blocks, this is going to be an in-plane technique right over the gluteus muscle. And we'll go over the bony landmarks on the next slide. But you're typically going to use the curvilinear probe for this particular nerve block, especially in patients who have a larger body habitus. So here is a clip of the anatomy for the nerve block or hydrodissection. So the muscle on top is going to be the gluteus muscle, and then the bony structures on screen left right now is the greater trochanter. It's going to be the more rounded hyperechoic structure, and then the kind of flatter bony structure on screen right in this case is going to be the ischial tuberosity. So your goal is to look for these two bony landmarks, and then you're going to find a nice circular hyperechoic structure running between them, which is going to be the sciatic nerve. If you're having any difficulty finding the sciatic nerve, you can scan inferiorly, and sometimes it can become more obvious, and then trying to scan more proximally to do the actual nerve block to get the most kind of improvement in your pain just because you're more proximal. So this is an example of the actual nerve block happening in progress. So we have a bony process kind of here on screen left. That's most likely the ischial tuberosity in this case, just based on the shape of it. And then you're going to see this circular structure in the middle, which is hyperechoic. That is the sciatic nerve, and then you obviously see the linear hyperechoic needle coming in with anechoic area surrounding it. So the goal is to bathe the nerve just like any other nerve block with the either anesthetic or in hydrodissection case, D5 or normal saline. And this is going to allow for the either numbing or compressive neuropathy release. As you can see, there's really no vasculature here, so it allows for maybe the more nervous providers to kind of use this nerve block as maybe a jumping off point because it has a great safety profile and there's really nothing else that you can hit here that would be concerning in terms of vasculature. And there's your sciatic nerve. So to kind of differentiate between the two, we're going to start with the transgluteal sciatic nerve block. So this is going to be an injection of the local anesthetic, like most other nerve blocks, with bupivacaine, ropivacaine, lidocaine, plus or minus your additives, typically any sort of steroid. And the mechanism for this is the direct anesthetization of the sciatic nerve and its branches. And the benefits, theoretically, this would be a longer duration of action, especially when using a steroid medication to help kind of prolong the effects. And the risks being local anesthetic systemic toxicity. Ideally, this will be avoided, especially when we're calculating doses to find the maximum volume that we can use based on which medication and concentration we're using. But specific to this nerve block, the concern is risk for motor blockade causing foot drop, which can lead to falls. Typically, this is transient, so some places actually just send all of these patients home on crutches to help kind of mitigate that risk. And then to contrast that, the transgluteal sciatic nerve hydrodissection, the injection is typically with dextrose 5%, which is what most of the studies show. And then normal saline is also commonly used for this particular procedure. So the mechanism is a little different. The thought is to release the compressive neuropathy with any sort of muscle spasm or piriformis spasm that is pressing on that sciatic nerve. This allows for release of that compression and hopefully pain relief in these patients. The benefits obviously being that there's no risk of motor blockade or foot drop or local anesthetic systemic toxicity, with the concerns being that potentially a shorter duration or lower efficacy. But we're going to go into the current research and really show you kind of what's been done so far so you can make an informed decision about when to use either block. And the first case we're going to talk about is a prospective study investigating the clinical outcomes of patients with sciatica receiving the transgluteal sciatic nerve block in the emergency department. There were 63 patients in the study with statistically significant decrease in pain scores at both time of discharge and also at 48-hour follow-up. There's also an improvement in ambulatory status for these patients, and only 1% of these patients had a complication of a transient foot drop. So this study was a kind of concept of introducing the hydrodissection as an alternative to the treatment of acute sciatica in the emergency department. It was a case series indicating the success of these patients and their improved pain. And then here is a great abstract of a prospective case control study comparing the traditional medication management to the use of hydrodissection in the emergency department with an improvement in pain scores compared to the control group. And then more recently, this was a great case study showing a patient who came in for bilateral sciatic nerve pain due to the concern for transient foot drop. They didn't want to perform a block on bilateral sides, so they did one side with a transgluteal sciatic nerve block and the other side with a hydrodissection. The patient went from 10 out of 10 bilaterally to 2 out of 10 on the nerve block side and 0 out of 10 on the hydrodissection side. And the patient did not have a return visit to the ER. So it's a cool study kind of showing both of these procedures done on the same patient with great success bilaterally. So overall conclusions, both the transgluteal sciatic nerve block and hydrodissection are effective pain control methods for the acute sciatic pain patient in the emergency department. Hydrodissection may have a slightly better safety profile, but as we discussed, there's a very low percentage of any sort of complications in these patients, and typically this is a transient foot drop that will go away with time. But if you want to mitigate this risk, that is a great option. And there would be kind of a need for further research to determine prospective studies directly comparing the nerve block to the hydrodissection to see if there's any difference in clinical outcomes. So the question is, which one will you choose and when? If you have any questions, please reach out to me. I want to thank my mentor, Dr. Michael Jones, and then my fellowship director, Dr. Trent Shea. Thank you.
Thank you, Dr. Sales. I'm thrilled that the only fellow who could not make it here today happened to be my own fellow. That's always good to hear. She is currently in Forks, Washington, not in Olympic yet, which is a favored town of mine because of the books that I have read. So in lieu of asking her a question, I just wanted to quickly thank all the fellows for the presentations that have happened and that are going to happen. We in the background, we've been saying this has been a really, really good crop of talks. I think it's very, very close to the top in terms of judging. It might actually come down to that tie-breaking popular vote. Everyone here has done a fantastic job and should be proud. I've learned stuff. I don't know. I can't speak for the judges, but for the people that are organizing, we're learning stuff just sitting here, which is just amazing. And I think even if only one of you guys can unfortunately take home the top prize, but all of you should feel very, very proud at what you have accomplished because they're great talks across the board. Okay, so I'm going to move on. So our next speaker is Dr. Jinx Leoy. His mentor is Matthew Pyle, and he is going to be talking to us about, beyond the emergency department and global health, which chronic diseases can be diagnosed and monitored with point-of-care ultrasound. So Jinx, if you are on, this is all you. I see your slides.
Can you hear me now?
I can hear you. And
Second, it's been a long time since I've used Zoom. And getting
as an aside, our hospital and our residency is getting rid of Zoom. So next year, Microsoft will be dominating.
Can everyone see then the title slide?
We can see your title slide. We do not see presenter mode. Go for it.
Awesome. All right, everyone. So yes, my name is Jinx Leoy. Thank you for joining me for my talk about life beyond the ER and global health when you are the whole hospital. And so my objectives today will be to discuss focus applications in 5 common global health clinical situations. We've already heard a little bit about global health in general, and I think most people, if not everyone here, knows how broad of a topic ultrasound and global health is. And so my goal is not to talk about all that because it would be here all day long, which I would be excited for. But we all have other things to do. And so the focus will be on 5 situations: HIV, extrapulmonary TB, pediatric lower respiratory infections, chronic kidney disease, cirrhosis and portal hypertension, and gestational age dating. And so as I'm talking through this as well, thinking about the earlier presentation where we're in rural Tanzania, where you can't get labs for a day, if at all, and your only imaging modality might be the handheld probe that you brought. And so things are going to be a little limited. And so how can we manage clinical situations with limited information? And so starting with the FASH exam, or HIV and extrapulmonary TB, this is the focus assessment with sonography of HIV-associated TB. And so realistically, what we're doing is looking for very similar things to what FAST would show, which is extra fluid where it shouldn't belong. And so here we have our standard right upper quadrant and left upper quadrant positive FAST exams, which would be the same. The difference is that in extrapulmonary TB, we start to see these fibrinous connections in the fluid, as highlighted here in the yellow. And so these would be more concerning for extrapulmonary TB. And why that matters versus just regular pulmonary is that the duration of treatment is much longer. And obviously, then sometimes they can get a little bit sicker too. And so then other things to look out for in this protocol is looking at the spleen directly, because sometimes it can be infiltrated with the extrapulmonary TB, and it oftentimes is. And so here you just have, again, our regular standard left upper quadrant. However, when we switch to a linear probe and more high frequency in general, we'll start to see these hypoechoic, anechoic lesions right here, which would be more telling for that extrapulmonary TB, and again, can help us manage things. And then the last part, and probably the most different between the FAST and the FASH, is that we're looking at the abdominal aorta. And so what can happen again is that the TB can infiltrate the periaortic lymph nodes, and you can start to get these masses as highlighted in the yellow here, where if this was seen again, it would be concerning for extrapulmonary TB. And additionally, and again, with people then with HIV, the percentage of them actually developing extrapulmonary TB is about 50%. So most people who have HIV who get TB are likely to have extrapulmonary TB. And so moving on then to bronchiolitis and the pediatric lower respiratory tract infections, we've all had that one kid who comes in, they're sniffling, they got snot everywhere, they maybe have a little bit of retractions, but it's not super concerning, not calling the PICU right away. And so you suction them, you give them some Tylenol, and they start to perk up. The problem is when you auscultate their lungs, they still sound junky. And so now you're nervous because you're thinking, can I send them home comfortably?
Jinx, I think you just muted yourself. We last heard can you send them home comfortably? Don't know how that happened. You are now unmuted.
Yay.
Congrats.
Thank you.
Cheers.
Technology. Never thought I'd be the one saying that.
Please keep going.
So you have the Lespro system for these kids who are in this gray zone. And so this breaks it up into 3 different sections on each side of the lung, with the upper, lower, and lateral. And so what you can do then is score them using the scoring system, with the first one being A lines, which is normal lung siding or a 0, non-coalescent B lines scoring 1, coalescent B lines scoring 2, and subpulmonary consolidations greater than 1 centimeter or atelectasis scoring a 3. And so any child that has a score of 6 or higher indicates that they are going to need monitoring. And so then you can comfortably say, hey, no, you need to stay for a little bit longer. I'm worried that you're going to get worse. Or no, I think you're going to be okay, and you can go home. And so now moving on to the non-communicable, we have the chronic kidney disease. Can we give the acetaminophen or ibuprofen? And so typically in the ERs here in the United States, in particular, when we're looking at the kidneys, it's either in a FAST exam or we're looking for hydronephrosis. And for chronic kidney disease, we really need to look beyond the sinus at the overall echogenicity, its length, the cortical thickness, and the parenchymal thickness. And so starting in our standard right upper quadrant, we have our liver and our kidney, and both are a similar echogenicity, which is darker than the surrounding soft tissue. And that's exactly how it should be. However, as kidneys start to get injured, we see that they start to become more echogenic. And so this is very sensitive, but not very specific for chronic disease. And so how we can increase our specificity of this is truly chronic is by looking at the cortical thickness, the parenchymal thickness, and the overall renal length. And so combining all of these, and you see a very sick kidney like this, where the cortical thickness is significantly lower on the right side versus the left. It's very bright. You can't really distort, like all the architecture is distorted. This person is probably on their way to dialysis. And so you can tell them like, hey, you need to go to a bigger city potentially to get better care. And so then in cirrhosis and portal hypertension, oftentimes we see a traffic jam. And so in the United States, this usually happens because people are drinking too much. But around the world, it can be alcohol or other vector-borne diseases that oftentimes will infect and cause damage to the liver itself. And so again, starting in our right upper quadrant, we have this nice pretty picture. Everything's very happy. But then we get injury to the liver, and now it's the one that becomes hyperechoic compared to the kidney. And see, then it's even kind of indistinguishable from the surrounding tissue as well. And if the issue progresses and then you develop portal hypertension, some of the other very quick visual assessments you can do is look at the spleen on the other side to see if you're developing these dilated collateral vessels. And so very quickly we can say that doesn't look right, versus doing maybe some of those more advanced Dopplers, which we might not be able to do with our handheld probes. And so looking at this, we can very quickly say this spleen isn't having a good time, and there's probably portal hypertension being developed as well. And lastly, another finding you can do very quickly is just look at the spleen itself, and you can see that there's these hyperechoic infiltrations kind of scattered throughout. These are called gamma antibodies, and they're very specific for portal hypertension. It's just crystal deposition that can occur in the spleen as well. And so lastly, gestational age dating, when are you due? Probably everyone's worst nightmare in the ER. You have a pregnant person coming in, they're clearly got a baby bump. They've never had any prenatal care. And so you're kind of freaking out like, what do I need to do? But the difference is you don't have a OB-GYN that you can call, and you don't have the formal ultrasound that can be doing anything. And so around the world, unfortunately, particularly in Africa and Asia, a lot of people are not getting very good prenatal care, if any at all. And so it really can be important for us who are coming to these other regions and using the ultrasound to give them at least an estimated gestational age, so that they can plan accordingly, because maybe they do have to go hours away to get to any higher level labor and delivery system. And so historically, you talk to your OB-GYNs, they're going to be doing bipyramidal diameters, humerus lengths, abdominal circumferences, and finding the head isn't really the hard part, or finding the femur necessarily isn't the hard part, but distinguishing where you need to measure specifically once you get those calipers are. You need to make sure that the cartilage is not there, or you need to make sure the falx cerebri is there. And that can be difficult, especially in some of these lower resolution machines that we might be using. And so there's an alternative called the fetal foot length. This has actually been around since the 80s, and not really sure exactly why we don't do it in the States as much, but it has been compared with femur length as well as bipyramidal diameter, and they are equal as far as predicting gestational age. The difference is sometimes it can be a little bit harder to find the foot, but the nice thing about it is that once you do find the foot, this is a very simple measurement. So you go from the tip of the toes all the way to the heel, and you're done. And there's plenty of charts available online that you can then compare the length with that. And so sometimes, again, it might be a little bit difficult. This foot kind of blends in with the rest of the stuff. So it might not be the perfect system, but when you're in an unknown area and you don't have as much backup, having as many tools available can be really helpful. And so in summary, ultrasound and global health are very big topics. We've had multiple conversations about them today already. I hope that with this, you just have a couple more tools available that can help you take care of people in low resource settings. And so thank you to Matt Piles, as well as my department as well, for supporting me in my journey.
Thank you, Jinx. The foot dating is really interesting. I've not done that. I think I struggle whenever I see a third trimester pregnant patient. I struggle finding that femur length, and then femur length is not as accurate. But the foot is really interesting. Do you do that just now if you see a third trimester patient in your ED plus minus?
I haven't yet, but by doing, I have been kind of really looking into a lot of these things, and the fetal foot length is something I discovered. I haven't seen many pregnant people in the ER, and I'm a family doc actually, so I'm in clinic half the time. And so I haven't used it yet, but I think I've inspired most of my department now to try and find a foot when we're doing it.
I'm going to be trying that. That sounds pretty cool. Thank you again for your talk. So before we progress on to our last talk, I just want to say we currently have a tie for first place, so we probably are going to need that tie-breaking popular vote. So apologies, Dr. Agaraj. I'm going to put the popular vote link. There's a Google form into the chat. Please don't vote until all the fellows have finished presenting. We have one last presenter. But after the last presenter, if you can go on, it's a simple question: who is your favorite presenter? And this is going to help us figure out the scoring at the end. So last but not least, I want to introduce Dr. Irene Agaraj with her mentor, Daniel Brenner, who has, what a wonderful title, The Wonderful World of Regional Anesthesia, a New Spell for Shoulder Pain. So Irene, please.
Thank you.
take it
I
away.
actually don't have access to share.
Oh,
I don't
okay.
think.
Let's see if we can fix that. Hold on. Try now. You should be okay. All right.
Can you guys see my presentation?
We can see your presentation.
Okay.
We do not see your presenter modes. Go right on ahead.
Okay, awesome. So hi everyone, my name's Irene Agaray. I'm one of the fellows at Yale. And today I'll be talking to you all about the wonderful world of regional anesthesia and use spell for shoulder pain. Special thank you to Daniel Brenner from Indiana University for his help with my presentation. So I'm going to set the scene. I know we all feel like wizards from time to time in our emergency department shifts. So I'm going to introduce our wizarding world where you are an ultrasound fellow, you're learning new spells and learning how to better take care of patients. So you are your flying lesson when one of your classmates has a fall off his broomstick. He's brought to the infirmary and he's diagnosed with a proximal humerus fracture. You help out when you decide to call orthopedic surgery. They say, no problem, this is non-operative, we'll see the patient next week in our clinic. He can go home in a sling. You go to discharge your patient and he's kind of upset with you that you want to discharge him in this condition, in a lot of pain. Let's pause and talk a little bit about proximal humerus fractures. They represent 5% of all fractures seen in the emergency department. They increase in incidence with age, especially after age 60, and are usually sustained after a fall from standing height. So effective pain control is crucial, especially because these fractures are managed non-operatively, and non-operative management has been shown to have better outcomes, but opioids are not going to be our best choice. They provide ineffective analgesia and are associated with adverse risks such as respiratory depression. So you know that nerve blocks have been used in the emergency department for multimodal pain control, especially in shoulder injuries. So you decide you're going to try out a new spell for your patient. You open up your spell book and consider the most common type of nerve blocks that are used for upper extremity injuries. You know that brachial plexus can be blocked at multiple locations, and you decide to look into the interscalene and the supraclavicular blockiosum. And you look through these blocks to see which is going to be more suitable for your patient. Our interscalene block provides anesthesia to levels of C5 to C7 of the brachial plexus. Notably does not work for the inferior trunk C8 to T1. So it's a great choice for shoulder and upper arm injuries. It does not provide effective analgesia to injuries below the elbow. So not a great choice for things like elbow dislocations. One thing to note about the interscalene block, as I'm sure we're all aware, it almost inevitably causes hemidiaphragmatic paresis due to involvement of the phrenic nerve as it runs super close to the space where we perform this block. There's also a small but present risk of pneumothorax because of how close the pleural line is to where we perform this block. Now you consider the supraclavicular block. This block is also known as the spinal of the arm, so it is great in analgesia to almost the entire upper extremity, and it's used for a wide array of indications, for humerus injuries, for elbow dislocations, for hand lacerations. And you remember it still carries some risk of hemidiaphragmatic paresis. About 50% of cases you'll get an ipsilateral hemidiaphragmatic paresis, so a little bit less in the interscalene block, but still present. And still a very small risk of pneumothorax. And our nerves are going to be a little bit less tightly organized in this region, so there's a little bit more of a risk of nerve injury. You also remember that your attending brought up a new type of block in your lecture last week, the interfascialis blockiosum. So what is this block? This is a new type of regional anesthesia technique that targets the axillary and a little bit variable blockade of the musculocutaneous nerves. So unlike the traditional axillary nerve block that's performed at the posterior shoulder, where the axillary nerve exits the quadrangular space, this block is performed in the anterior shoulder in the interfascial plane between the deltoid and subscapularis. So the goal of this block is to inject anesthetic in this region to lift the deltoid off of the subscapularis muscle. What are going to be our indications for this block? So this block provides analgesia to the anterior and lateral shoulder and a little bit of the upper arm. So it can be effective in multimodal pain control for proximal humerus fractures. It's actually a great option for acute on chronic shoulder pain and frozen shoulder. What are some pros to this block? So because we're targeting an interfascial plane, we're going to have spread of our anesthetic to the anterior and lateral sensory nerves of the shoulder. We're not going to have much motor blockade. So this is great for our elderly and frail patients who are sending home, and we want them to have good shoulder mobility. There's also not going to be a risk of hemidiaphragmatic paresis or pneumothorax, which again is great for our elderly and frail patients. And it's relatively easy. We'll go over the technique in a minute, but it's a great block for those who are starting out doing nerve blocks, or a great block to allow your intern to do. What are the cons to this block? So as we've talked, it's not a super versatile block. It can be used in multimodal pain control, but by itself, it is really limited to the glenohumeral joint. And as with all nerve blocks, I didn't mention before, but there's always a risk of LAS or local anesthetic systemic toxicity, infection, and bleeding. So how are we going to perform this block? Our patient is going to be supine. The shoulder is going to be externally rotated and abducted slightly. This is going to kind of move our biceps tendon away, which is lateral to our needle trajectory. And we're going to be using an in-plane approach with a probe marker pointing cephalad. And our ultrasound probe is going to be placed between the coracoid process and the humeral head. So our landmarks are going to be, again, the deltoid, the subscapularis muscle, our humeral head, and we want to see our needle piercing this interfascial plane. And by the way, an interfascial plane block is just a fancy way of saying it's going to be a block performed in between two deep fascial layers. Once we're in this spot, we're going to see a nice unzippering of our anesthetic like we see where our asterisk is. So which anesthetic do we want to use? We all know that lidocaine, bupivacaine, and ropivacaine have different duration of actions. Our lidocaine is going to work fastest, but it's going to have a short duration of action. Bupivacaine is going to give us the longest duration of action, but we all know that there is a little bit more risk of cardiotoxicity. And ropivacaine is going to be somewhere in the middle in terms of its duration of action, with a little bit more favorable safety profile. When I did research on this block, the most commonly used anesthetic that I saw was bupivacaine at 0.25%. And we're going to be using 20 mLs. And what about adjuncts? So shout out to Lachlan, who is presenting today, but looking at the block registry, which looked at approximately 2,700 nerve blocks across 11 emergency departments, epinephrine did not show improved immediate block efficacy, whereas Decadron did, so we can consider adding Decadron to our block. Knowing all this information, we decide, let's give this a shot on our patient. We use our ultrasound, we identify the anatomy, we see the deltoid muscle, the subscapularis, and the humeral head, and we see where our target is going to be. Let's watch this being performed in real time. As you can see, we see a really, really nice linear spread of our anesthetic in this fascial plane. And now we can go ahead and dump the 20 mLs of our anesthetic. We check in on our patient. He's looking much better, and he feels happy that he's able to go home with his pain a little bit better controlled. So in summary, while we have our tried and true interscalene and supraclavicular blocks, they do pose a very real risk of hemidiaphragmatic paresis, which may not be the best choice for all of our patients. So I want us to think of the interfascialis blociosa, especially when we have a proximal humerus fracture or someone coming in with acute on chronic shoulder pain. We're going to remember that we're targeting the proximal axillary nerve with a little bit variable blockade of the musculocutaneous nerve. And there's going to be a lot less adverse risk, and it might empower us to be that cool attending who's letting interns do nerve blocks with us. And that's all I've got.
Awesome. Thank you, Irene. That was a great talk. I gotta be honest, when you submitted your talk, I Googled it and I tried it and it kind of worked. I'm pretty sure I screwed it up, but I thought that these are some really cool new techniques that are out there, especially for phrenic nerve sparing blocks, because I've definitely had those patients where you do your block for a proximal humerus and suddenly their O2 sat drops and you're like, well, at least they're not in pain anymore, but then I have to admit them or something. So thank you for sharing.
Yeah, I actually did it on a patient who got admitted for like bilateral PEs. He happened to be in an MVC, was an incidental finding. He had a proximal humerus fracture, and I checked on him the next day, and he said his pain had been pretty well controlled after
Nice.
the block.
Nice. I just gotta get better at it. So thank you again. So to wrap up, if you guys could go ahead, for all of you audience members, feel free to click on the link. I'm going to send it again, just so you guys can vote on your best audience choice. I'm going to send it through here again. And while we tally up the scores, we again, shout out to everyone that spent time here today. Thank you to our audience, our fellows, our mentors, and of course our judges for spending all this time. And again, we are finalizing our scores. I want to give another thank you to my subcommittee leads, Jonathan, Javi, and Sandy, who have been working behind the scenes throughout this event. And for anyone interested in becoming more involved with ACEP Ultrasound, this symposium was organized through the Fellowship Education Subcommittee, which is one of more than 20 subcommittees within the ACEP Ultrasound section. There's a wide variety of groups depending on your interest. There's simulation, there's AI, there's system point of care ultrasound leadership, there's a new one for regional anesthesia. Each subcommittee has its own Google Group mailing list that you can literally look up on Google Groups. And if you're interested in joining one, feel free to reach out to that particular subcommittee. You can look up for it on Google Groups. And if you have any issues, feel free to email me. I'm happy to connect you. We are also hoping to host this symposium again next year. So for current fellows and especially mentors who may want to work with future presenters, we would love to have you involved again. And just, I wanted to give another thank you to everyone who has been involved, the fellows, the mentors, the judges who spent the past 2.5 hours listening to some really incredible talks made by all of you. It's, as someone, we're tallying up the scores right now, and it's really tight at the top. And I think all of you have done a very, very good job today in terms of preparing your talks, and I hope that this was a very valuable experience. So, Jonathan, I don't know if you've had the chance to look for all three.
Yes, I have them almost fully tallied. I'll send them over to you right now.
All right. Okay. Strong. Again, winner of the talk, you will be invited to present at ACEP 26 during the ultrasound section meeting. That's in October. If for some reason you can't make it, our humblest apologies, but you will be invited. And thank you again. Okay, we are waiting on some final audience votes. So get your votes in if you have not.
I do want to say everyone really did an excellent job. I learned so much about things I've never even heard of. So I'm excited to get into the emergency department tonight and try some of these things. So great job, everyone.
Yeah, just echoing what Francis said, everyone did such an excellent job. They were so polished. You were all so prepared. Thank you so much for devoting so much time for all these amazing talks and teaching us. I learned so much.
Yeah, me too. Thanks, everyone. That was great. I can't wait to find a baby foot.
I have a couple new blocks to try.
So cute. I will certainly email it out.
Okay. Looks like we got it. Okay, so I'm going to go from reverse order. So coming in third place, Dr. Lachlan Driver with Why We Shouldn't Do Nerve Blocks. Lachlan, congrats. You were also the top audience vote. So congrats, top popular vote. Yay, 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 yay. Coming in second place, this was a tie break for the top, is Dr. Christine Donat for ultrasound JVP. Really, really close. And again, congrats. And in first place, we have Dr. Ochan Kwan about meat models and fidelity. So Ochan, congratulations. You were first by a hair, but still, it was excellent, excellent presentation. So congrats to Drs. Kwan, Donat, and Driver, and to everybody else. Well done. And I got to tell you, I'm looking at the scores right now. It is super close. Like the top 7 are separated by like 1 point. Like we had to go to like half 0.7 points. So to tie this all up, this has been recorded. So I'm going to send out a link to all of you guys when I actually get it. And if you guys have any questions, feel free to reach out. And thank you all so much for your time today. And I hope you guys have a good rest of your night.